But you're working, no?
Muka nyumbani, it's work, worse work, ni kazi mingi kuliko hata medicine. Let me just tell you. Okay, we are on live on Facebook. I think you can start. I'll fish the link. I will share it, but you can start.
What's your Facebook page? What's your name on Facebook?
That so I largely left Facebook. It's a page. Let me share. It's called Authentic Dialogue.
Authentic.
With Saya. It's my it's a page, for those who join me on
yes,
Sundays.
I'm following you.
Yeah, that's a page. Okay.
Okay.
Now link haikuji. Okay. I'll copy link. There we are. Okay, and you go ahead. Let me hop off camera. Karibuni, Njoki ndio mgeni mashuhuri. Mimi tu kelele ndo naletanga. Bye bye.
So I can share my screen. So good evening, ladies and gentlemen. If there are any gentlemen present, and thank you for joining us on this session, initially initiated by PB Club 96, but of course, anyone and everyone sharing this discussion, primarily because I suppose as a class we felt we are at that age where then menopause is becoming a concern. But then we also know many people who can benefit from this conversation. So we welcome all of you to have this 1 hour or so of conversation, and we invite you to put your questions in the chat. My name is Dr. Njoki Fernandes, like you've seen there, consultant obstetrician gynecologist, and wanting to share some insights, basically to start a conversation around this area of menopause. And it's a discussion. Please feel free to ask your questions. Please feel free, and let's have a conversation. All right. So by way of introduction.
Sorry, Njoki, could you put your slides from the beginning so that we at least act surprised when we see the other slides?
Okay. And sorry, some are bombing. So close the door. Sorry, I'm at home. All right, so there we are. I had forgotten to start the slideshow. So by way of introduction, our female reproductive system, or the female reproductive cycle, is a continuum. Unlike men, where it continues throughout their life from the time they're born until late, in their 70s. From the ladies, we have kind of like a starting point and an ending point. And if we remember our biology, or what we were taught, is that from around 20 weeks in utero, when we are in our mother's wombs, we have the total number of over half up to the point of menopause. So we start with a certain number of eggs, maybe 20 million, from the time we're 20 weeks in our mother's wombs, and the eggs keep reducing in number. I'll try and make it very simplistic so that we all understand. The eggs continue reducing in number, and you don't get new eggs being formed. So one day, they will get finished. And then now that is what is termed as menopause, when you have no new ova to ovulate, right? And so menopause marks the end of the reproductive life of the woman, of the female. And the most distinct sign is a cessation of the menses. Most distinct sign, but it's not the only sign. So for example, if you do not have a uterus, if you had a hysterectomy earlier on, of course you will not have menses either way, but there will be other signs to show that you are approaching the menopause. And we say that you are in menopause after you have been having an absence of the menstrual period for 12 continuous cycles without any other known cause as to why you do not have your menses, meaning you're not pregnant or you're not under the influence of any medication or any treatment. So 1 year, 12 months without menses, it can be concluded that you are in menopause if you do not have any other cause. And then we also need to define perimenopause is a transition period which can last 5 to 10 years before the actual menopause sets in. And there can be some symptoms even with the presence of menses. So for those of us who are around 45, 46, 44, we could probably be in the perimenopausal phase where we are experiencing certain symptoms, even if we are still getting our menses. Yes. And the average age of the menopause average is 50 to 51, but it can start as early as 45. And we find women, even at the age of 5, are still not in menopause, but on average, 51 years people. Yeah. So what symptoms are we looking at? Should we anticipate as the ovary ages? It's actually the aging ovary that we are discussing. And what symptoms do we experience? Like I said, the symptoms can begin in the perimenopausal phase, which can be 5 to 10 years before the actual menopause begins. And one of the things that you will find, you have irregular menstrual cycles. Sometimes you will get menses twice a month. Sometimes you will get menses once every 3 months. Sometimes you get very scanty bleeding. Sometimes you get very heavy bleeding. It's a whole mishmash. And irregular menstrual cycles is one of the signs probably that you are in the perimenopause. And then another symptom that can be very disturbing, and so we'll discuss it in a bit of detail, is what we call hot flashes. It's a phenomenon that we'll discuss that is characteristic of the menopausal period. We also have sleep disturbances. All of a sudden, you have insomnia, you're waking up in the night, you're not able to sleep well. And then, of course, this affects your day and your function. And then mood changes. You find that you're getting increasingly irritable, and you're impatient, and you're not as intolerant as you ordinarily would. Then we also have vaginal dryness, loss of vaginal lubrication with this problem we will see. And then we can also have bone weakness, because we will see estrogen it helps with bone deposition of calcium into the bone. And so when the estrogen is no longer there, you find that more bone is resorbed than is deposited. And so you have bone weakness and osteoporosis. We've talked about irritability, yes, mood changes, and sometimes people can even get depressed. If you are already have depression or already having low mood, this can be aggravated by the onset of menopause. People suffer from skin changes. So you have skin dryness, and you have your hair is thinning, and sometimes it even falls off. And then you have increased growth of hair on the face. So the hair distribution adopts a male phenomenon. You know, men have reduced hair on the head and increased facial and body hair. So this is what we see as you're transitioning menopause, all of a sudden you have facial hair, you have hair in other parts of the body, and thin hair on your head. And then we also have weight gain in the truncal area, what we call truncal weight gain. We have the pot that doesn't seem to go away no matter how much you exercise and no matter how much you diet. You find that you're not able to lose the weight in the truncal area. We've talked about joint pains, we've talked about memory impairment, and we also have reduced libido, also because of the effects on the genitalia, which we shall see later. So what are hot flashes? Hot flashes are the sudden sensation of heat centered on the upper chest and face that suddenly become generalized. It lasts from 2 to 4 minutes and associated with profuse sweating and occasional palpitations. May be followed by chills and shivering and a feeling of anxiety. It can occur several times per day and can disrupt normal activity. And hot flashes are particularly common at night. So what causes hot flashes? They're commonly caused by changing hormone levels before, during, and after the menopause. And the hormone that is actually most implicated is estrogen. And studies are beginning to show that the vasomotor symptoms may be as a result of dropping estrogen levels and the changes that occur in the brain that is in charge of controlling our body temperature. So we realize that the body thermostat, which is controlled by the brain, is affected by dropping estrogen levels. And these reduced levels are the ones that are sensitive to subtle changes in the body temperature. And this is what causes the hot flashes. And then in relation to hot flashes, you also find that some people who, when they're not getting hot flashes, they get very cold. So like now, the way you're finding that it's a bit cold in Nairobi, people who are going through menopause feel very cold. And then when it's hot, they feel very hot. So the thermoregulation actually becomes a problem. And then we have genitourinary changes, the changes in the genital system, and they develop later, slightly later than other menopausal symptoms, because it takes some time for the estrogen reduction to be felt in this area. So you have atrophy of the vulvovaginal area, which is changes to the labia, to the clitoris, to the vagina, the urethra, and the bladder, caused by lowered estrogen levels and decreased blood flow to the area as a result of the lowered estrogen levels. And then this causes decreased vaginal lubrication and sexual dysfunction in menopausal women. It also causes increase in yeast infections. And this vaginal dryness can also cause painful intercourse. Other genitourinary changes include frequent urinary tract infections, stress incontinence, and urge incontinence. Stress incontinence means that when you cough, you leak urine. I think you've had that experience once in a while, but the sphincters are also tightened by estrogen. So when the estrogen reduces, the sphincters become a bit weak. So when you cough, you leak urine. And urge incontinence means that you're not able to hold your urine long enough to reach the bathroom. Sometimes you find that you're not able to hold, and when your bladder is full, you leak before you get to the bathroom. And these symptoms are responsive to estrogen therapy, especially vaginal estrogen therapy. And so this can be used to help manage the symptoms. So what are the long-term effects of menopause? And I think this is what we need to be concerned about. So there is the increased risk of dementia. We said that you have memory problems. People who are undergoing menopause usually have what we call brain fog. Yeah, brain fog is that you're not able to remember things. You'll get into the kitchen and you'll wonder, why did I come? What was I looking for? You forget your keys, you forget appointments, you forget even things that you shouldn't be forgetting. If you are very good and you are very organized, all of a sudden you're forgetting stuff, yeah? And some people can actually get dementia as they grow older. So in this case, then you need to be organized, get a diary, use your phone more to diarize things so that you don't forget. And then there's an increased risk for cardiovascular disease, the heart and the circulatory system. Remember that estrogen is cardioprotective. It protects the heart and protects the cardiovascular system. So when the estrogen levels drop, then we are at the same risk with men for cardiovascular disease. And then we have GIT problems, bloating, constipation, and irregular bowel motion. Some people in the menopause really suffer from this, especially because they say the progesterone is reduced as well. And then we talked about osteoporosis. There's the loss of bone mass, and the bones can easily get fractured. And this is a very real risk. And we find that women who are in menopause are at a high risk of fractures. And then endometrial cancer, especially for patients who are on hormone replacement therapy, yeah, and those, one of the major symptoms is postmenopausal bleeding. Increased risk for hypertension and diabetes. Remember, we said that once estrogen is no longer part of your system, then you're at a higher risk of getting these other problems. Increased risk for depression, we talked about it. We said patients who are already having low mood and get into menopause can get depression. Increased risk for breast cancer, especially for patients who are on hormone replacement. There's a big controversy as to whether hormone replacement causes breast cancer or not, but it's a target organ for estrogen. So if you have unopposed estrogen, it's some literature says it increases breast cancer, some literature, there's still a controversy around it, but I just put it there for the sake of completeness. Some studies show that it increases your breast cancer risk. So osteoporosis, a bit to talk about it. During the perimenopause, you begin to have bone loss, which is demineralization of the bone. Because of estrogen, there's not enough deposition of calcium on the bone, and the bone matrix begins to weaken. And then incidentally, people with a higher body mass index are associated with a slower bone loss. I suppose it's because they're carrying more muscle, yeah? And people with a lower body weight have got a higher rate of bone loss during the menopause, yeah? Sometimes, apart from estrogen deficiency, you can get bone loss because of taking steroids, malabsorption, or hyperparathyroidism, especially in patients who have got prematurely occurring menopause. And I'll go into that into a bit. Sometimes you can get premature menopause. So bone loss is a real thing. And one of the things that we really need to observe as we are going into the menopause is to think about bone loss. And of course, if you get fractures in the menopause, they are more difficult to heal. They take longer, and they are manipulating the bones is usually more difficult. Yeah. So a healthy bone, just a picture there, compared to an osteoporotic bone. A healthy bone has got nice compact bone matrix, and the osteoporotic bone has got many gaps. So the bone is not strong and can easily can easily fracture. Yeah. Okay. So what is premature ovarian failure? Sometimes you can get into menopause before the prescribed time. So we said average age 51. Some people can start getting into menopause from the age of 45. But sometimes you could find that patients get into menopause before the age of 40. Yeah. And there are many reasons as to why you can have premature ovarian failure. Sometimes it's just a thing. Some patients just get into premature ovarian failure from the age of 35 with no known cause, no known underlying cause. But you can also have ovarian failure. So for example, if you've had radiation to the abdomen and your ovaries are radiated, then you can go into menopause. Or your ovaries are removed as part of treatment because maybe you had cancer of the breast or cancer of the ovaries because we wanted to remove the source of estrogen. So then you can also get ovarian failure. Yeah. So anyway, the point is that you find that a woman goes into the menopause from the age of 30, from the age of 35, and it can be very distressing. All right. And we need to make an early diagnosis so that we are able to manage and control the complications that we've talked about. And we know that the risks are accelerated in people who get into premature ovarian failure earlier than those whom menopause occurs naturally. So then how do we make a diagnosis of menopause? Of course, usually a good clinical history. Yeah, if you go to the doctor and you tell them your story, usually the story is leading towards menopause. You will talk about your symptoms and we are able to pick out the history usually is very indicative of menopause. Yeah. And then of course a physical examination will corroborate the clinical history. So we will find the skin dryness, we will find the truncal, we will find the, all those things, the vaginal dryness and things like that. Yeah. So we are able to corroborate the history with the clinical examination. Of importance are laboratory checks. They're tests that we do to check for certain hormones or certain stimulating hormones. So blood tests. And at this point, I'd like to say that the lab tests are usually quite expensive. And many times the insurance companies might decline to pay for these tests. But they're important, especially you need to go to a good lab that is able to give us a good test result so that then we are able to get a good diagnosis and to treat. Yeah, so the lab tests can be expensive and they're quite extensive. I think the menopausal panel where I work is like, it's 10,000 shillings for a menopausal panel to make a diagnosis of menopause. And that's not small money we accept. But yeah, lab tests are critical, but they can be quite expensive. If you're on hormonal contraception, we can miss a diagnosis of menopause because hormonal contraception, you tend to have a withdrawal bleed every month. So you assume that you're on your menses. There's a patient the other day who came and she was 54 and she was complaining that she's not in menopause, but she's still taking pills. So it's likely she went into menopause a long time ago, but she wouldn't know because she's on hormonal contraception. So we usually withdraw the hormonal contraception and see if the patient will manifest features of menopause. If you're on hormonal contraception, of course, you will not have menopausal symptoms because you're still getting exogenous estrogen. Yeah. So then, management of menopause. The first thing is that it's normal, and that's why we're having this conversation. It's a normal process, and for ladies, the menopause will come. You might never be a mother. That one is not a guarantee, but all of us will go through menopause at some point in our lives. So it's important that we get to know that it's a normal process and to be reassured that it's normal. And then you need to visit a good doctor to avoid chama remedies. What are chama remedies? Chama remedies are those remedies you talk about in the chama. I was feeling like this and I took this. I was feeling like this and I was given this. Or they even bring for you the treatment they're taking for the chama meetings. This is dangerous because menopause treatment is highly personalized because people's symptoms are different and people's bodies are different. Yeah. So visit your doctor and do not take what is being circulated. Also, look out for danger signs. Like in the menopause, if you've not had bleeding for a year and then you start having abnormal bleeding, then that is a danger sign. It could be a sign of cancer, or it means your uterus is receiving hormones from somewhere. Yes, and that we need to check. And then pain, abnormal pain in the abdomen or in the breast or in the reproductive system, anywhere. Infection that's not going away. Those are danger signs that you should not ignore. And then nutrition. Remember, we said that you need to eat well to make sure that you're not deficient. And then physical exercise for two reasons. One, to manage the osteoporosis, the bone loss, and two, to manage the obesity that tends to happen when women get into menopause. One of the things that we usually tend to forget is psychosocial support. We find that many women get into mental distress when they are going through the menopause, and this mental distress affects their relationships with their spouses, with their colleagues at work, with their children, with their families. And so sometimes they actually need therapy to help them navigate this process, because maybe even they themselves are not sure they don't understand what they're feeling and why they're feeling what they're feeling. So it's important to get psychosocial support. If you're having conflict with your spouse about it, it's good to have conversations, to get someone to mediate in the sense of, so that you can get the psychosocial support you need to go through this. Management is usually not just the gynecologist alone. We usually have the physician involved, especially if you're going to be started on hormone replacement, like we're going to see, and the psychotherapy team, the psychiatrists or the psychotherapists, and other experts, like we need them nutritionists, etc. Yeah? So how do we prevent osteoporosis? An optimal diet with adequate intake of calories, calcium, and vitamin D. You need to eat well. And sometimes, because we want to lose weight or we want to get rid of the pot, remember truncal obesity, we deny ourselves adequate food, and this can be a problem. Remember, you need to have adequate intake of calcium and vitamin D, either as dietary intake or as supplements, okay, to make sure that you have enough calcium, all right? If you're not eating enough, then you can take supplements. And the recommended intake is 800 international units of vitamin D per day and 500 to 1 milligrams per day of elemental calcium. And then we are told that weight-bearing exercises and posture training is like yoga and Pilates, help increase the bone mass density. So strength training, lifting weights, is actually better than cardio in managing your bone strength. And then if you have a high risk of fractures, there is a test we do called bone DEXA. There's a test that you do to check, and bone density is really low. You may need medical therapy to reduce bone resorption and facilitate building of the body mass. There's some medication that we give intravenously for those patients who have got fractures or who have had risk fractures, okay? So then we have to give specific medical therapy. So how do we manage sexual dysfunction? This is an area of concern, naturally, and there are many options. But please remember, ladies, that you need to get medical help. You cannot do these things by yourself because we titrate the lowest dose for the effect that you want. So this is something that you need to do with the help of a clinician. And as we are titrating the dose, we are also monitoring side effects. So please do not try this at home by yourself. Please seek medical guidance. And even if you're not in a sexual relationship, sometimes you find that you need to be assisted, especially for your own comfort. Yeah, for your own comfort, you need to have some of these treatments done. So the first one is testosterone. Yeah, testosterone is a male hormone, and trials show satisfying sexual desire, arousal, and response increasing significantly in patients who receive a controlled dose of testosterone. Hormone replacement therapy, I'll talk about it in a bit, is also useful in managing sexual dysfunction. There's a new thing that is called vaginal Botox. The way you have Botox injections on your lips or in your eyelids, they also have vaginal Botox, which is said to increase lubrication. I'm not sure if it's true, but for sure it's expensive and not very practical. I would imagine it's also painful, but it's a thing in some parts of the world to increase lubrication and I suppose manage sexual dysfunction. We know that you need to lose weight, yes, and to have a healthy diet. General body fitness and pelvic floor exercises. Remember we talked about incontinence, where you leak when you cough or you leak when you have a full bladder. To prevent that, you can do Kegels exercises, yeah? They're called pelvic floor exercises, yeah? It's like you're passing urine and then you hold for 10 seconds. You pass urine, then you hold for 10 seconds. And that one you can do the whole day, even as you're going about your affairs. That strengthens your sphincters and helps to reduce the leaking, all right? So if you have prolapse is where the organs are in the wrong place. Sometimes you can have cervical prolapse, you can have rectal prolapse, you can have bladder prolapse. Then you need a specialist. Yeah, they're gynae specialists who are able to help you with prolapse and incontinence that is not being managed by exercise. All right. And then lubrication. Lubrication, especially during sexual activity, there are many options. KY jelly is water-based, so they say it dries up, but you can also use coconut oil, sweet almond oil, and they're also lubricant and they have no side effects. The only problem is that they're oil-based, so then cleaning can also be a challenge. And KY is water-based, so it washes off easily. Yeah, and sometimes we've talked about Kegels exercises, and some people might require surgery, especially if you have organ prolapse. I think the most important thing in managing of sexual dysfunction is patience and time. So your sexual partner should also be aware so that then they are able to give you a bit more time and to be a bit more patient, okay? So hot flashes, how do we manage hot flashes? Hot flashes can be a problem and they really affect the quality of life. They affect the quality of life for many people because the hot flash will come as you're working. You can imagine you're in a meeting, you're presenting a serious pitch, yeah? And remember, at the age at which you're going into menopause, you're also at the top of your career, isn't it? You're now doing very well, you're thriving, you're the CEO, you're the finance director, you're the manager, you know, you're up there. And so you find that as you're growing career-wise, you're also getting stressed by menopause. So it can really put a damper in your growth. So you can be there giving a presentation, and then all of a sudden the flash comes, and it comes so dramatically. You start sweating, you want to fan yourself, you want to undress. It's really bad. Yeah. So sometimes we need to manage hot flashes so that you can manage your quality of life. So how do you manage a hot flash? You reduce the room temperature. Yeah, try and remain as cool as possible. Light clothing at night. Don't cover so much. Hydrate. Yeah, it's difficult to say avoid stress, but avoid stress, and limit spicy food. Some people get triggered by spicy food. Have lukewarm to cold showers. And if you're having severe hot flashes, you need to consider hormone replacement therapy. And where HRT is contraindicated, you can use antidepressants and some anti-epileptic drugs that can be prescribed. Remember, hot flashes are a thermostat problem. Your body is not able to quite thermoregulate, and that's why you're having this issue. But you need to manage it because it can really affect the quality of your life and your function. You can have 3 or 4 hot flashes in a night, which means that you're going to wake up 3 or 4 times in a night, and that affects the quality of your sleep, which is not a good thing. Yeah. Hormone replacement therapy is a big thing, and one that we need to discuss because it has a lot of controversy, but also a lot of value if used properly. So it's also called menopausal hormonal therapy, and it is used to treat hot flashes and genitourinary symptoms of menopause. Yeah. The benefits outweigh the risk for healthy symptomatic women who are within 10 years of menopause and younger than 60 years. However, I need to put a disclaimer here and say selection is very key. Menopausal hormonal therapy is not for every patient. Yes, and in as much as we say that the benefits are good and the risks are low, it is very, very specific. It's very specialized, very specific, and very individualized treatment. So you cannot start HRT on your own. You need to be guided by your doctor. So who are the people who cannot take hormone replacement therapy? If you've had a history of breast cancer, if you have coronary heart disease, if you have hypertension, if you have diabetes, you have atherosclerosis, if you have anything to do with heart disease, if you've had a stroke or a previous venous thrombotic event, a clot, a blood clot, or even if you have history in your family of blood clots or coronary heart disease, if you have active liver disease or cancer of the cervix or of the uterus, whether it is active or a history, you cannot use hormonal replacement therapy. So apart from hot flashes and genitourinary symptoms, we know that estrogen manages sleep disturbances, mood swings, depression, and in some cases, joint aches and pains. So the choice of the preparation of the dose is based upon the patient preference, drug availability, and the cost of the drug. So the side effects of the hormones: breast soreness, breast tenderness. Remember that the breast is a target organ for estrogen. And so if you get high, and I suppose you also get breast soreness at some point in your cycle, around the time of ovulation. Yes, we get breast soreness, and like premenstrual, you get breast soreness. So it is a side effect of high estrogen, which can be minimized by using lower doses. So sometimes you can get irritability and bloating, especially with progesterone therapy. Vaginal bleeding will occur even after the menopause. Yeah, even after the menopause, if you take the estrogen progesterone regimens, you will get a bleed. Yeah. But the low doses, you could manage without getting a bleed. Yeah. And vaginal rather than oral administration of progesterone capsules tolerate. So I need to say that if you have a uterus, and you're taking HRT, you must take estrogen and progesterone. If you do not have a uterus, then you can take estrogen alone. Why we need an estrogen and progesterone combination is because we need you to have a period at the end of every month. So that is why you need a combination of estrogen and progesterone if you have a uterus. Yeah. So lifestyle changes. We need to make some lifestyle changes in HRT treatment and in the menopause in general, so that then we are able to manage this situation and to manage it well. The first lifestyle change that we need to talk about is exercise. We've talked about strength training and weight-bearing exercises. Yeah, very important for your bone density. Balanced diet, speak to your nutritionist and include all the food groups, including fats. Yes, remember cholesterol. We need cholesterol necessary for hormone synthesis, the hormones that we are lacking. Avoid processed foods as much as possible because they have high chemicals, they have high salt, empty calories. Yeah, if you have GI symptoms, you could consider going dairy-free and gluten-free. Increasing your fiber intake. Read more. You can do crocheting, knitting. Let's reduce our screen time, the time you spend on the phone. Yeah, we need to socialize more, talk to people, engage in events, church activities, Rotary activities, club activities, join a choir, join a dance group, whatever. Yeah. And then reduce alcohol intake and stop smoking. Not reduce, stop smoking. All right. And then increase intake of probiotics, such as supplements and other sour foods. Fermented foods are very good. Kombucha, kimchi, yogurt with probiotics, very good. Fermented foods are very, very good for symptoms of the menopause. We've talked about vitamin D and calcium supplementation, biotin for thinning hair and nails, and intermittent fasting is very good because it helps you manage, not only manage your weight, but also manage insulin resistance. And you need to reduce your sugar intake to what you can tolerate and what is minimally acceptable. Avoid high sugar foods. Yeah. Supplements. There's a huge industry for supplements in the market today. Supplements for menopause. What do you take? What don't you take? Whether you are on HRT or not, you need to speak to your doctor about whether you can take supplements because sometimes they interact with the medication. If you're not on HRT, you can try whatever seems to be working. The other rider is that both HRT and supplements for menopause are expensive. Yes. And why am I saying that? If you get very cheap products, I'm not sure they're genuine. Yes, it may sound cliche, but the market is flooded with all manner of things. But for some reason, the proper supplements and the proper medication for hormone therapy can be expensive. So just to warn you that if it's very cheap, then it's probably not the correct one. Yeah. So there are certain supplements you can take, like black cohosh, which reduces hot flashes and night sweats and improves the mood. Vitamin D, if you're deficient, you can take some. It helps with poor concentration and mood disorders. 5-HTP is converted to serotonin to improve mood and better sleep, and it has an antidepressant effect. Maca powder is available in the Healthy You shops and other places. It improves libido and hot flashes and balances your hormones. Omega-3, evening primrose oil, and shatavari. Yeah, shatavari is an Ayurvedic herb, Ayurvedic way that is found in India, and it's very popular in India. And I suppose it works because they are a populous nation for the menopausal transition and libido enhancement. So they're all these, yeah? And you can find them in the Health U shops, Good Life Pharmacy, and many of these pharmacies in town, yeah? But it's good to have a conversation with your doctor so that we agree on the dose and the frequency, yeah? So this is my last slide, just to remember that there are other tests that you need to do as you're starting on your menopause journey. We need to do cervical cancer screening, and there are many forms. Bilivia, there is pap smears, HPV testing, breast cancer screening. You can do the mammogram. Usually after a certain age, you don't do ultrasounds anymore, you do the mammogram. And there's a protocol that we follow, so you need to see your doctor. Thyroid function tests are as part of the hormone profile. HbA1c is to check for diabetes, for your sugar control. So if you do not have good sugar control, then we do OGTT and check if you're diabetic. Renal function tests, of course, to see how your kidneys are functioning in the long term, especially if you have hypertension and diabetes. Cardiac stress test to check out your cardiac function, and other cardiac tests as may be indicated, the ECG, the echo, etc. Colonoscopy and endoscopy are an important screening tests, and pelvic ultrasound, especially if you have abnormal pelvic bleeding. You can also have other tests that can be performed, including biopsies of the endometrium if you have abnormal bleeding. We need to check your cholesterol, we need to check your vitamin B12 and your vitamin D, among other tests. So you can see the workup is extensive and can be quite expensive. Why am I insisting on cost? So that when you go to the doctor, you're not shocked when you find that they're asking for this test and that they can be quite expensive. Just to know that these are tests that need to be done. Okay. So for the purposes of time, it's been an hour. So I'd like to stop there so that you can ask questions. Thank you very much for your kind attention. And I'd like to acknowledge Dr. Mutindi Kakuti, class of 95, who was very useful in some of the insights that I used to prepare this presentation. So thank you, and over to you for questions.
And you can raise your hand and ask questions. Njoki, what's your take on vaginal estrogen?
Vaginal estrogen is good. It helps with some of the symptoms of dryness and some of the local symptoms. And because it's local, it doesn't have the systemic effects and probably the systemic side effects. So you can have vaginal estrogen in as ovules, or you can have it as a cream. So it's been known to work very well. Yes, so it works.
Okay.
Primarine and the like, yeah, so it works.
And just a bit of a caveat for the ones who are using, what are they called, herbs and supplements. If you're on other medication, please confirm with your doctor or pharmacist, because they might interact with your drugs and make them, render them useless. So just be afraid. And they could also mess up your yes. And they could also render your birth control useless, and you can get an oops baby at that age.
Now that you mentioned that, Posa, there are two things. One, that HRT is not contraception. So you might think that because I'm taking estrogen, progesterone, you're on contraception, you're not. And because of the high FSH, LH levels that you find in the perimenopause, sometimes you can get an oops ovulation, yes, and an oops ovulation, even sometimes you can even conceive twins. You can get a multiple pregnancy in the perimenopause. So you need to remember that it can happen. We've had ladies who come pregnant in their 50s, which is okay, I suppose, but it's usually distressing if it's not planned. So HRT is not contraception, and to know that you can actually conceive in the perimenopausal phase. Even if you've not had your menses for 6 months, you can actually get pregnant. So to be aware of that.
Any questions, Monsieur Ogope? Any questions? Oh, Dolly, go ahead. Dolly Morithi, go ahead.
Thank you so much for the chance to, and thank you for the presentation. Now, my question is, if you get, say, for example, diagnosed with early symptoms of menopause, say at 37, 38, and maybe you get pregnant, can that baby have issues? Can you get a normal baby, or you need more attention than you'd need if you didn't have the symptoms of menopause?
Right, like I said, even in the normal menopause, in the perimenopausal phase, you can still get pregnant. And if you do get pregnant, then of course the pregnancy will be normal, unless there are any other issues. Of course, the younger you are, the easier the pregnancy is to manage, yeah, both for the patient and the medical practitioner. So unless there would be any other issues, I would imagine that if you get premature menopause and you get a baby, I mean, thanks be to God, yeah, you're lucky, but it's also good to have very close monitoring so that we support you through that pregnancy.
Any other question?
Hi, my question is to do with brain fog. Is there a solution to it? Hi, is there a solution for it? No, for real, because I'm a teacher and seriously, I think sometimes, you know, where students are telling you, you said something and you're like, I could swear those words never left my mouth. As in seriously, like I totally just forget. It's insane. Is there a solution? Okay. Because you said biotin for thinning hair. What do we do for brain fog?
Okay, we said that the human, the HRT has been shown to improve mental function, and there's some other supplements that you can use. If you just research, there are quite a number you can use for brain fog. Again, individualized, but also use tricks. You know, write things down. Use small notes. Put things in your diary. But it gets better. You see the beauty about these menopausal symptoms, that they don't last forever. At some point, you will settle and life will go back to being normal. So the idea is to support you during that time when you're feeling a bit of pressure. So there's some symptoms we can dig up. There's some supplements we can dig up and see what helps. Also, they say brain exercises. So for example, Sudoku and Scrabble and crossword puzzles, such mental stimulating activities will also wake your brain up a bit, and so
I teach physics. Isn't that more than enough brain exercise? I swear. I just don't get it. Like seriously.
No, but for you, physics is not brain exercise. It's a second nature.
Okay, maybe. All right.
So try other things that are not in your realm. So Sudoku, Monopoly, Scrabble, chess, you know, things that stimulate your mind in different ways, just to keep you, you know, keep your mind going. And it's a phase. It'll end.
And also don't discount sleep. I should do a presentation on sleep. I'll look for a specialist. If none, we will do. Sleep is important. Nobody on this earth should sleep under 7 hours. No one.
That's true.
So sleep, and then because we've gotten thicker with age, there's something called sleep apnea. So we are not getting enough sleep, and most of the fogginess we get is actually lack of sleep. And as Kagwe asked about fatigue, for most menstruating females, iron deficiency is am I allowed to curse? Is a bitch. Iron deficiency is a very big deal, and sometimes the just measuring your HB level doesn't capture it. There's something called ferritin that needs to be measured, because sometimes your HB could look okay, but your iron stores are abnormal. And then we are going out there and donating blood, which is sucking out more iron. So the fatigue could be sleep and just your iron level. So, and mtu asikudanganye, as an Adventist, it's not your mbogas which will give you. You need to eat enough animal source of protein. And if you're deficient, you cannot get away with take a supplement, a recommended supplement.
Mm-hmm. That's true. That's true indeed. So yeah, there you have it. You need to sleep. If you're not sleeping, then you already have a problem in that area of brain fog. You'll be tired. You'll not be able to function. Sort out your iron deficiency, and maybe even your nutrition. You're not eating well. You know, you're tired because your nutrition is a problem. Someone is asking, how long is HRT recommended for? And after stopping HRT, will the menopausal symptoms still present themselves afterwards? So HRT, like I said, is individualized, and the idea is to take the smallest dose for the shortest period of time. Yeah, just to tide you through the symptoms and to get your body to get used to the lack of estrogen in your body. It's like you're going through withdrawal. So sometimes when you're withdrawing from cigarettes, they give you nicotine patches to try and make your body kind of get used to the withdrawal slowly. It's a funny example, but anyway, so like that. So you will not have the symptoms forever. However, there's some people who suffer some periods, some symptoms for long. So that some people will suffer hot flashes for 10 years. Yeah, but it's usually the exception more than the norm. The same way, like in pregnancy, you find that some people who have got sickness the first 3 months, and there's some people who have mornings, nausea and vomiting the whole pregnancy, isn't it? So people differ, but to answer the question, I don't think they will persist after a certain period of time. But again, individual. The idea is HRT, if you must take it, the least dose for the shortest period of time. Yeah, and that's why you need to have a doctor keeping an eye on it for you. Yeah, Hilda, you have a question?
Yeah, I have a question. Thanks a lot, Njoki, for the presentation. Very helpful. I was wondering if we look at like a family history, like if we look at our moms, for those who have elder sisters, aunts, can we sort of predict the kind of menopausal symptoms we may have, or maybe the age we will get into active menopause by looking at family history?
Yes and no. Yes and no. Sometimes yes. You could kind of predict based, especially if it's consistent. You know, if your mom had symptoms and maybe your other sisters are having kind of the same thing, so you could anticipate that. But you could be pleasantly surprised to find that you are on your own path, or you could be the one having a dramatic menopause and everyone else is just you. So yes and no. But if there's drama in your relatives, it's probably good to anticipate that you could be in that mix, so that when it doesn't happen, you're pleasantly surprised. Yeah, sometimes it doesn't follow the rules, sometimes it does. So yeah, it's like that. What is the average menopausal period? I'm imagining you mean how long it takes. Is that the question? It depends. It depends. Some people 6 months, some people 1 year, some people 3 years. It also depends on how you manage your symptoms. Yeah. Some people just have a very rough 6 months and then they're okay. Some people have got underlying medical issues that they make the menopause last longer and has got more issues. It also depends on your general body composition and how healthy you are. And that's why we are having this discussion, so that if you're healthier before you get into menopause, it is anticipated that you will have a bit less drama and a bit less pain. Yeah, so it can take 6 months, it can take 1 year. You can have symptoms on and off, but you're not too bad, or you can have a dramatic time. So if we can be proactive in already preparing, that would really help. Yeah. Dolly, your hand is up.
Thanks again. For me, I'm 37. I was diagnosed with, is it premenopause symptoms just a month or two ago, and the doctor I saw mentioned that it's because I have a history of multiples. I have twins, and my sister as well was diagnosed at, I think, 39. And he mentioned that it could be a cause for early menopause, because he also mentioned that it's because we release like 2 eggs a month or something like that, because we get twins all the time. Has that anything to do with it, or it's just a family history, or yeah?
So do you get fraternal twins or identical twins?
Fraternal.
Are you fraternal? But you
Yes.
see, you cannot assume that you ovulate 2 eggs every month. That's an assumption, isn't it? 37 is early. That's premature menopause. Even if you have twins, a history of twins in the family. I'm not sure. Okay, I don't want to discount my colleague, but well, okay, if you say so. I'm not sure. I'm not sure. I don't know what the others think, Osa. I would look for something else, but I hope you're managing it adequately, because you have a long way to go in that menopause journey.
And did we mention the age? What's the rough average age that people get menopause in Kenya? I know it kept on changing because our grandmothers didn't know their age and they were dying young. So we didn't have an age when Askies were in med school. But currently, do we have an age? Do we know?
Around 51, what I was reading, 51. But some people in 55 are still not in menopause. But perimenopause from around 45. And that's why we are in that age group, isn't it? Because we are the 45ers. So we are the ones now who will already begin to feel perimenopausal symptoms. But younger than 40 is premature. And it can happen. Again, it happens in some people just genetically. So for Dolly, maybe you and your family have a genetic predisposition to early menopause, and it's okay. I mean, we just manage. Someone is asking, are there permanent health implications of the menopause? I talked about them, and that's why we need to keep an eye on them. We talked about osteoporosis, we talked about heart disease, we talked about joint issues, we talked about mental issues, we talked about diabetes, we talked about hypertension. Yeah. And so those are the things that we need to keep an eye on with regular screening. Yeah, obesity and all the things that go with that. So that is why it is a concern, so that we need to make sure that we're keeping track on all these parameters in the menopause. Yeah.
As we're thinking about the next question, I want to advertise the next topic. I really hate sharing my screen. Are you able to see that? That's our next topic. It's going to be on 4th of July. At least the people stateside will be able to join because it's a holiday here. It's our Madaraka Day. Yeah, it's about thriving in our 40s, and Joanne, she's not ex-PB, but she's ex-Mary Hill, so sisterhood over there. We're gonna talk about emotional intelligence, boundaries, and just discovering our inner child. So the same way you got this link, you will get this link for the 4th of July. I think it's the week after, next week, I think. Okay, if there are no questions, we kept time, so we need to go do other things. Kenyans need to eat and sleep. People, yeah. Thank you, Njoki, for starting us out.
Thank you very much for all your kind
Can I
attention.
do an appreciation?
Emma,
Hi, Emma, how are you?
okay, go ahead.
Hi, Emma, how are you?
Fine. I think on behalf of everyone here, I want to give a big vote of thanks to POSA for organizing us. Njoki, that was excellent. We've all learned. I also logged in. I've listened the whole time. And I also want to thank everyone who has joined. I thought I should do it from the crowd now that Njoki and POSA, you really took charge of us. So really, thank you. We appreciate you. Thank you, POSA. Thank you, Njoki.
Njoki,
thank you, class of 96. Thank you for encouraging us to do this. And we encourage more conversations in our alumni group, and you know, just to keep our conversations going. And when we have our webinar, please let's join in and yeah, and learn so much. Someone is asking about how do we engage for prescriptions. You can side chat me, and we can see what works for you where. And could you also get a list of the recommended supplements? Yes, Reba, you can side chat me as well. And we can share what is available. Someone is asking for me to share my number. Wait, Pastor, how do I do this?
If you're comfortable, just type it there. If you're not, write your office number. Yeah.
Meeting group chat. I don't remember my office number. I mean, so 248942, or you can find me on social media. I don't mind. These are our sisters, yeah. So we can have a conversation and we can see how we can help. Yeah. Okay, Posa, over to you. I think we've done our 1 hour.
Yeah, we've done our 1 hour plus. I think, yeah, Reba, that's I think it's Njoki's text and WhatsApp
yes, that's
number.
our WhatsApp number. Yeah. Yes. Mm.
This is Reson's sister, Reba.
I don't know.
Okay, and Jackie, thank you for joining us. Oh, it's okay. Okay, kwaherini, and see you next time. Please join us. And if you have a topic and someone who wants to speak about it, just let us know. We are open. Even if you're not from PB, we shall welcome you.
Yeah, we shall. Let's have the conversations and let's keep ourselves informed. Yeah. Thank you, everyone. Have a good evening. Happy holidays to those in Nairobi. Happy work days for those in the diaspora.
You're pushing it now.
Thank
okay,
you
bye-bye.
so much. Bye.
Bye.
God bless you.
Bye.
Okay, bye-bye.
We have learned a lot. Bye.